Anyway, contrast resolution. Remember whenever you're reading questions on resolution to look for the qualifiers. Contrast resolution just means black and white, the difference in adjacent, the anatomical densities in adjacent structures. Okay, so those are the things you're going to look for. Density differences, contrast. If the question asks for spatial resolution, that's your sharpness. Now you got to have both, and sometimes we have a tendency to confuse one for the other because they're hard. You can't have one without the other. You know, if you have spatial resolution without contrast resolution, the image is all one shade, and you can't make out any differences, right? So you have to have the contrast resolution to make the spatial resolution stand out. At the same time, if you have good contrast resolution and everything is pixelated, you just can't see anything that way either, right? So you have to have them both. And so sometimes we have a tendency to confuse even visually, like what we're talking about earlier in your presentation. You said this sharp image. Okay, well, what does that mean, right? In terms of radiographic sharpness, it's that spatial resolution. In terms of actual visualization and seeing it, it's a perceptional thing, right? So make sure that on the test, you don't confuse the two. The spatial resolution is sharpness of the lines as opposed to contrast resolution being the difference in densities representing the things on either side of that line. Okay, so when we do KUBs, we start off with chest x-ray, and the next thing we do is KUB. And with KUB, it's hard to see stuff except for the spine and the pelvis. And usually the first thing that you can pick out are those psoas muscles, because they have a little bit higher density, and you've got the separation at different tissue types, so you can make them out a little bit. And then eventually you start to be able to visualize the kidneys and maybe the inferior border of the liver. Certainly you can see the gas patterns because totally different tissue types. But that's your contrast. The question is, how sharp is that interface between the two? And that's your sharpness recorded detail. So, make sure you don't confuse those two. Contrast resolution. Contrast just means difference in density, as opposed to spatial resolution is how sharp are those lines. All right, so it makes the diagnosis of pathology possible. And again, like we were talking about last week, whenever we change to digital processing, even in CR, our dynamic range or the clarity of those contrast levels became so much more significant that we could stand to lose a little bit of sharpness to gain that perspective. So it's in the patient, it's most affected by tissue type, less so by KVP, but tissue type, tissue thickness, tissue density, thickness, density, and type, all kind of have the same effect on the image. The higher any one of those things get, the more absorption we get. So it's a change in differential absorption, change in how much is emitted by each one of those tissue types that gives us a contrast. KVP decreases the differential absorption, and you get more penetration of all tissue types, but it just doesn't manifest itself on the image in the same way now as what it did before we went to digital processing. Higher KVP just doesn't show up as low contrast as what it used to. So again, this is poor contrast resolution. It's not because anybody selected the wrong technique. It's not because of positioning issues. It's because we've got a lot of adipose tissue. So a lot of tissue, especially any kind of tissue that creates more scatter radiation, is going to give us a low contrast image, even with digital processing. Probably not as significantly as what it used to, again, before we had digital processing. So this is higher. And I put the in parentheses because it's still a KUB. A KUB inherently is going to be low contrast. But if we back it up, where are the kidneys? You can kind of make them out. Okay, so there's one, and there's the other. How well do the psoas muscles stand out? Not very good. And then we go to this one, And you can see the psoas muscles, you can see the inferior border of the kidney here. So much higher contrast, and this is solely because of tissue thickness. So this is what we used to get with the difference between, you know, high KVP and lower KVP, or possibly with and without a grid. Now, we never really had to use a grid for a chest x-ray, and the textbook answer for why you don't need a grid with a chest x-ray is because of the natural air gap. Whatever, you know, the natural air gap would be the distance between the heart and the image receptor. Really, it's because we've got extremely high contrast tissues that we're shooting through, right? We've got a little bit of fluid filled structure in the heart and great vessels, but the great vessels are directly over the spine. So primarily what we're looking at is the difference between air and bone, right? So it's naturally high tissue contrast. So we can sacrifice a little bit of radiographic contrast, and it's not really going to hurt it all that much. And in fact, we don't want our image to look like this. And even on film, if we had an image that looked like that, that was a repeat. You did something wrong to get that, or your processing chemistry was messed up. That's not normal, even for film. But it wasn't as high contrast as what you got over here. I mean, this, in the days of screens and films, is a pretty good rib series. Okay, that looks like normal chest x-ray now, right? But yeah, it's because we've naturally got that higher dynamic range. We pull out contrast differences much better than what we used to. So anyway, low contrast versus high contrast. And this great Bambino, low contrast, high contrast. We can just go on with that forever. So what causes a poor contrast resolution? That would be scatter radiation potentially can have the greatest effect on it, and that's usually because of increased tissue thickness, more so than what KVP does. So, but you know, just to cover our bases, theoretically, anything that increases the peak energy or pushes it towards the high energy side does increase penetration, right? If it increases penetration, it decreases differential absorption, and theoretically, because you penetrate more tissue types more evenly, then theoretically it could reduce your contrast. But how much? In a digital world, not that much, not that much. So if you were to shoot with, you know, you use your 15% rule and increase your KVP by 15%, reduce your mass by a factor of 2, you put those two images side by side, you're not going to see a whole lot of difference between them, right? Maybe even if you did it twice. So I talked about, you know, the kind of the evolution of technique as we went from screens to films, or screens and films to CR, instead of doubling the mass, because the image receptor system was twice as fast, or half as fast rather, right? Screens and films were 400 speed, and then CR was 200 speed. To keep from increasing the dose by a factor of 2, having to double our mass, then we increased our KVP by, you know, 15%. Remember talking about that? Okay. So DR, again, is as fast as screens and films, potentially even faster. So what we did was we, instead of decreasing the KVP back down, we just decreased the mass. Okay, so, and we haven't seen any kind of real effect on contrast. So could we do it again? Increase KVP by another 15%, cut our mass in half? We could. We could. Would we see a difference? I don't know. You know, we have a tendency to get locked into a specific mindset that KVP has to be this, you know, and KVP affects our contrast. And, you know, you go talk to some of the older techs especially, and that's what they're going to say is, what do you use to control contrast? They're probably going to say KVP. It doesn't. So eventually I think we're going to make a change where we increase KVP another maybe 15%, cut the mass in half again. And in that, we're going to cut the patient's dose down probably by, I don't know, maybe 20, 30, 40%, something like that. So there's no real reason. I mean, if somebody were to do an exhaustive study on it and determine that increasing the KVP by another 15% wouldn't have any kind of, ill effects on contrast or diagnosis, there's no real reason why we shouldn't, right? So I expect that may be something that you'll have to adjust to in the future, is learning to use higher KVP techniques. Just as it seems like the literature may have a 10-year lag before it makes its way into or catches up to what the practice is. So what's going to probably wind up happening is somebody's going to prove it, and then the hospitals are going to start using it, and then eventually it'll make its way into the textbook. But just thinking about it from all different aspects, as you increase KVP and decrease mass, patient dose goes down. What happens to heat in the X-ray tube? What causes most heat in the X-ray tube? Higher mass, right? So if we increase KVP and decrease mass, what's the effect on our X-ray tube? Yeah, less heat, more life, less tanning, less chance for arcing. There's nothing bad. There's only net benefit in increasing KVP and reducing mass. So all of that stuff is what either increases the peak energy or increases the height or pushes it towards the high energy side.
So, okay, so increasing filtration, since it filters out the low energy photons, it pushes it towards
the high energy side. Yeah, with filtration, there is a difference between filtration and everything else in one respect, and that is that the height of the bubble comes down.
Okay.
So then we have to increase our mass. So yeah, so everything else, I think everything else up there increases the height plus pushes it towards the high energy side. Filtration reduces and pushes.
Well, all of that causes more contrast, low contrast.
Theoretically. I'm going to say theoretically. The thing that controls your contrast is your computer algorithm. Yeah.
So
traditionally, that did.
Test-wise, would we need to know, as far as changing our KVP, changing our, brim spectrum to the high energy side would cut our contrast resolution?
No.
Okay.
No. I think even on all the tests for the rest of the semester, the question will be something to the effect of what controls your contrast in a digital world, and that would be your computer algorithm. Yeah, so it's going to be lookup table computer algorithm.
Yeah.
If there's anything else, it would be tissue thickness.
Yeah.
The top tissue.
But that's just patient.
But that's patient,
Yeah.
right? So the machine factors is always going to be the computer algorithm. Potentially, I'm going to throw this in there too. Potentially grid use collimation.
Yeah.
Yeah.
No, a big scale.
Yeah.
Yeah.
Okay, so the one potential downside that I don't even know exists anymore is as we increase our KVP, reduce our mass, we introduce the possibility of quantum model, right? And I don't know that anybody has, and the data set is insufficient if anybody has, but I don't know that anybody's really done enough to try to introduce quantum model on our new machine. On our GE that we had, we couldn't get quantum model to show up. People shot thin anatomy with as high KVP as they could get and as low a mass as they can get, low KVP and low mass, could not introduce quantum model on the image. So our image receptors have gotten so sensitive that we still have to teach this because it's still on the registry, but it just might not even be a thing anymore, right? So what quantum model is a noisy image, and it's not noise caused by scatter radiation. It's noise caused by insufficient signal. So it doesn't have enough quantity. Quantum model doesn't have enough quantity to make a good image, and you get kind of a speckly, modelly looking appearance on the image. All right, so visibility is what we're talking about when we're talking about your contrast, those visibility issues. So things that will cover the visibility, or things that will cover the detail and decrease your visibility, would be scatter, if you had an incomplete eraser, reader errors, things like that. Fluorescent lights, if you're, and we established last week, nobody's using CR anymore, and CR is coming off the registry, but CR plates are sensitive to fluorescent lights. So they'll, if a plate sits, if you ever work anywhere that you're using CR plates, if it sits for 8 hours, it needs to be erased before it's used, to image anybody, because it's got a layer of fog on it, right? So erase it, just run it through the reader and the reader's eraser bank to get rid of all ghost images, and then it's ready to go. So excessive exposure, improper KVP, these will be in the extremes. You're not going to be shooting a hand with 110, 120 KVP. You could have some issues there. Same thing with mass. If you're going to lose contrast and visibility if you overexpose to the point. Think of your individual detectors kind of like empty cups, right? So you make an exposure, and think of the radiation coming through the patient kind of like water, right? So the water coming into those cups is going to vary by the tissue type that you penetrate. So bone isn't going to fill up as much as what is soft tissue, which is not going to fill up as much as what is, air or whatever, right? But if you make an exposure so much that you fill all the cups up, all of them are completely full, then what's your contrast going to look like?
Terrible.
You have no contrast, right? So, the things that affect sharpness or recorded detail, that would be, your focal spot size, your OID, angulation of the part, angulation of the central ray, SID, all those things affect your sharpness or recorded detail. So in that case, if you had, your anatomy as close to the image receptor as possible, and you were using an adequate SID with no angulation, what's your sharpness?
Pretty good.
Yeah, it's still good, but can you see it because everything looks the same? The answer is no. That's your sharpness versus your visibility. You remember me writing on the board? Yeah, that's sharpness versus visibility. Can you see it? Is it there, and can you see it? Sharpness is it there? Visibility is, can you see it? So you can cover that up with way too high exposure or way too low exposure, either one. So again, I kind of threw this out there last week as well. I think, what do you see here? It's just a foggy day, right? So, sun comes up, burns the fog off, and you can see the trees a whole lot better. You get up tomorrow morning, if it cooled down, you got another layer of fog, right? Does that mean that the trees are either not there or softer than what they were when the sun came out? No. Everything is the same, you've just got a layer of fog across it. So how to improve visibility would be to do all those things that we've already talked about. Use your collimation. PBL is not really a thing so much anymore, so it's incumbent on you to actually use collimation. What PBL is or was automatic collimation, so you'd slide a film inside the bucky, and it had sensors inside of it that would automatically collimate to the size of the film, which was great. And I think it's part of the reason that we're having a problem with collimation now is that it doesn't do that for you, right? So, people are just not taking the time to adjust the collimation and just sticking the anatomy on the image receptor and blasting away. So, PBL, and we had that problem before, and they introduced PBL to make sure that the field size was never larger than the image receptor size, right? Which is one of your cardinal rules of collimation. Never, ever larger than the image receptor size, and it should be collimated to the part. So collimation, cones, diaphragms are all beam limiting devices. KVP, meh. Grids, less meh, but still meh. Post-patient collimation, again, less meh. an air gap, I think, is borderline hokey. And then just saying like this. All right, so to improve image quality, good positioning, paramount, low OID, good SID. And I say good SID because you can use, theoretically any SID that you want to. 40 and 72, with in some cases 48 being an accepted deviation. Like in a freshman class, we're going through lower extremity right now. So if you're at 40 inches, your collimators may not open wide enough that you can get the entire tib fib if you put the tib fib on the image receptor from corner to corner, right? So how do you get a larger field size if your collimators are open all the way? Raise tube, right, exactly. So 48 inches, in some circumstances is a good good idea, but generally 40 and 72 inches. I talked about going to 10 feet last week. I think you get to a point of diminishing returns at best at 10 feet. You don't get any benefit out of it. Or I didn't anyway. So high resolution image receptors, good technique, all that. So then we'll go up to chapter 22, scatter control, factors that affect creation of scatter. Certainly the KVP, the field size, and we just talked about that, the patient thickness as well. So what we're interested in here is just the image forming x-rays, and that's what penetrates through the patient and eventually will strike the image receptor. So wide angle scatter radiation doesn't apply here. Compton scatter that does strike the image receptor, those are image forming x-rays, right? They're just x-rays that we don't want, so we've got to clean them up. We want to get rid of them the best we can. So the 4 pathways will be scattered away from the image receptor, and that's where you get your patient dose, is from the wide angle scatter radiation. Photoelectric, that's where we get our lightest images, transmitted through the patient without interaction is transmission. And then we get Compton scatter towards the image receptor. So with KVP, as KVP increases, a lot of stuff is going to happen. KVP is our most significant imaging factor. So we get an increase in the output from the X-ray tube. This is a brim spectrum all over again. We get an increase in penetration because we get more high energy X-ray photons. It determines whether or not we get a characteristic spectrum. All interactions increase, and this is where kind of lose people, because we have a tendency to think as KVP goes up, then we get an increase in scatter radiation and decrease in penetration. No, increase in penetration, increase in scatter radiation, right? Decrease in photoelectrics, but we don't. Why? KVP goes up, we actually get an increase in just raw numbers, an increase in photoelectric interactions. Why is that?
Because you increase all the different x-rays that are.
Exactly. When you increase KVP, you're going to increase you're going to get an increase in output of every energy level that you create. So what's the average energy level of a 99 KVP X-ray beam? Average. I selected 99 for a specific reason.
99.
That's the peak.
66.
Close. 33. So it's a third.
Okay.
It's a third, right? So the average energy is 33 kVp. So what are you setting 33 kVp to shoot? Your machine won't go that low, most likely, right? So we get an increase in photoelectrics, but we get a much higher increase in penetrated photons, and we get an increase in scatter. So in that way, we get an increase all the way across the board. All interactions increase with an increase in KVP. So we get an increase in penetration, we get an increase in scatter, and we get an increase in photoelectric. But percentage-wise, we get more penetration than what we get photoelectric. So that's why we say that as we increase KVP, we decrease photoelectrics. It's not that we decrease a number, but the percentage of photoelectrics compared to penetration and scatter decreases.
Does that add in, like, whenever it creates scatter, but then once it scatters through the body, it gets absorbed, like photoelectric absorption?
Yeah, is the short answer. More of those are even gonna penetrate through the patient.
Yeah.
So, you get multiple scatter events, and the likelihood of that photon, penetrating through the patient increases as well. We're still gonna get some photoelectrics, increased photoelectrics as well, but the patient's gonna emit more, a higher percentage than what it's going to, than what the patient, I won't say it, in reference to the patient, they're gonna emit a higher percentage than what they absorb. So both go up, it's just that photoelectrics go up this much, penetration goes up this much, right?
So can you give us an example of how you would word a question like that?
Yeah. Okay, so, and that's a great question. So it's gonna, make sure you understand the question first. So if I ask you a question that just says, as KVP goes up, as we increase KVP, what happens to scatter radiation? So your answer may be, your answer choices may be as KVP increases, we get an increase in Compton. Okay, so that's true. Yeah. Okay, so approaching this from 3 different directions. So that will be your answer. You get an increase in Compton. Or you may get a question that says, as KVP, it may be a true-false question. As KVP increases, all interactions increase. That's true. Right. As KVP increases, you get less differential absorption, more penetration. Both of those would be true, right? So that may be a multiple choice where there's some, but not all of the above. You may get one that says KVP increases, and it may be an all the above, where it says Compton's increase, penetration increases, and photoelectrics increase. Or you may have one that says, as KVP increases, the ratio between photoelectrics and Comptons, you get what is it, Compton to P ratio, you get an increase in photoelectrics compared to Comptons. That would be false. Yeah.
Yeah.
Or you get an increase in penetration compared to Compton.
True.
That would be true. Okay. So make sure that you read the question, carefully and understand what it's asking. So generally speaking, though, as when we're talking about KVP, we increase KVP, we get an increase in penetration, differential absorption decreases. So tube output increases, penetration, all photons increase. So again, as KVP increases, we do get an increase in fog, right? We get an increase in scatter radiation. Does that fog manifest itself now in reduced contrast? Not as much as what it used to. Because the main thing that controls your contrast is your computer algorithm. As a matter of fact, I should show you this at some point, and it might be in Canvas. Canvas was down all day yesterday. I didn't even know that Amazon owned Canvas, right? That was news to me. I had no idea. But Canvas was down all day yesterday, so I couldn't do nothing in Canvas. But I might have, where was I going with that? Where was I going with that? I forgot where I was going with that. Okay, so maybe it'll come back to me here in a minute. So field size, that's your collimation. Again, scatter increases as field size increases. And theoretically, and it's not really theoretically, but if you collimate for, like, let's say an L-spine, you make an image and then you decrease your collimation, make a larger field size, make a second exposure, your image receptor should show an increase in exposure. And that's partially because you're exposed to more of the image receptor, but also, the area where you were collimated before theoretically should show an increase in density. and because that's because of the increased scatter radiation strength. So as we increase our field size, then we get an increase in scatter radiation. So beam restriction limits scatter production. That's the key word here, scatter production. We got scatter production, we got scatter cleanup. Scatter production, collimation. Scatter cleanup would be your air gap technique. You've got your grid use or post-patient collimation, whatever, right? So since the increase in collimation removes photons, scatter radiation specifically in this case, it's going to adjust your density, your exposure to the image receptor. You want to replace that. And what you want to replace that with is mass at this point. Eventually it may be KVP, but at this point it's going to be mass. So we talked about that. Collimators are your variable aperture diaphragms. Positive beam limitation, I already talked about. No, I remember what it was. So look in Canvas and see if there's a link to the ARRT content specifications. And if there's not, I'll put one in there. There's a grid in there. You know, it's just this thing that has the different technical factors, you know, collimation, KVP, mass, and what they control. And if you look at KVP and match where KVP comes to contrast, has no effect according to the content specifications, which means that you should not be tested on KVP in contrast. So it's become so insignificant that KVP should not be on the registry in context of contrast resolution. Okay. All right. So beam limitation, all those. So collimation reduces the amount of scatter created because it reduces the amount of tissue that you expose. Remember that the content, the amount of scatter radiation that you create is dependent on really two things as far as collimation goes, or as far as patient goes. That is how much you expose this way and how much you expose that way, right? So if you expose more in either dimension, you're going to create more scatter radiation. And again, is that going to give us a significant difference in contrast? The answer is maybe not. We're talking about your collimators. We're talking about these are truly your variable aperture diaphragms. If you can look up inside of the X-ray tube, you have two sets. And I'm not talking about some that fold in this way and some that come this way. So what you have, let's see if we've got the diagram in there. Yeah. So what you have is this set down here, which is 4 shutters, right? These are the ones you're most familiar with. When you adjust your collimation, what you're doing is you're squeezing those together or spreading them out. But you got this one up here too, and this is what we refer to as a multi-leaf. And so what a multi-leaf collimator is, and if you do any rotations through radiation therapy, you'll see some of these. But multi-leaf collimators, in this case, this is kind of like a cone. And those, you know, it's got big chunks of lead, and those pieces of lead will spread out so that you can open and close those. So when you open and close, you're opening and closing, you know, you adjust your collimation, you're opening and closing those, but you're also opening and closing that as well. All right, so what these specifically are supposed to catch is, you see this little squiggly line that's coming up here? Anytime you see a squiggly line, that's supposed to be an X-ray photon. Okay, so what that's supposed to represent is off-focus radiation. So we had electrons that bounced, one hit here, created off-focus radiation. This is supposed to limit off-focus radiation. So on your test, if you see a question about what is the purpose for the multi-leaf collimator, that's not these. This is to protect the patient from unnecessary radiation exposure. The multi-leaf is this, and that's to protect against off-focus radiation. Okay. So the things, quality control wise, that you got to know about the collimators is that the light, you know, it has to be a perfect. Two things about the mirror actually. The mirror has to be at a perfect 45-degree angle. the distance between the focal spot in the mirror has to be identical to the distance between the light bulb and the mirror. That's because, we're dealing with electromagnetic radiation. It all behaves the same way. So it's going to diverge at the same rate. So if our focal spot is here and our light is here, then what we're going to have is, it's not going to be congruent. It's not going to be, the light field is not going to represent the radiation field. So they have to, the mirror has to be at a perfect 45-degree angle, and the distance between the mirror and the light has to be the same as the distance between the focal spot in the X-ray tube in the mirror as well. So that's one thing. The other thing is that if it's not at a perfect 45-degree angle, then what we're going to have is the radiation field is still going to come down this way, but the light field is going to bounce somewhere else, right? So what causes the mirror to be off is usually, it's mechanical. The bracing that caused it to be at that angle has failed for some reason. It's usually rough handling. People are just dragging the X-ray tube around and banging it about. All right, so perfect 45-degree angle. It has to be, when we talked about this, within 2% of SID. Remember the penny thing? 40 inches, a penny is like 0.75 inches. At 40 inches, that 2% is 0.8. So we talked about that. Vertical beam alignment within 2 degrees of vertical. And again, that could be due to a couple of things, rough handling or the locks being worn down. Distance indicator, first thing, it has to be present, make sure you don't break off the tape measure, and then it's got to be within 2 degrees of SID. Centering indicator must be within 1% of the SID. Again, often mirror issues. So patient thickness, we've already talked about that. Some pathologies may add air or bone or soft tissue. So where we have air, bowel obstruction. So what are your telltale signs when you walk in to shoot a portable KUB on a patient? What are your telltale signs that they've got a bowel obstruction? What's that?
Distended abdomen.
Okay, that's number one. They got a great big distended abdomen. So, how do you know that that's due to a bowel obstruction, or is it their anatomy? Anything else? Or maybe they've got ascites. How can you tell if they've got ascites? That's just fluid over all their body. Anything? How about look at their ankles? Can you see their medial and lateral malleolus? Any representation of it? Or do they have cankles? Well, some people have cankles. My brother had cankles. He wasn't that big, he had cankles. So how could you tell that it was his normal anatomy, or are they full of water? Ever seen somebody who's really, truly full of water?
Is it when you push your finger?
Bingo, yeah. So they're kind of like memory foam. So you mash down on memory foam mattress, and what happens? It comes back up, but it comes back slowly, right? You push down on a coil spring and move your hand, what happens? It comes back real quick, right? So patients who are full of water, they're going to bounce back, but it's going to bounce back real slow. So you push on their ankle, and if your fingerprint still stays there for a couple of seconds, that's ascites, right? But there's one other thing that should be the second thing that you look at. You walk into the room, you introduce yourself to the patient. Do they have NG tube in? And you should see that as you introduce yourself to the patient. Do they have an NG tube in? If they do have an NG tube, where is the NG tube? Is it hooked up to suction? If it's hooked up to suction, what does a suction canister look like? If a suction canister is full of bile, they got a bowel obstruction, right? And so all of those things are secondary. Really, you should be checking the chart, right? You should know why you're taking the x-ray. That's the first thing. But after that, those are your telltale indicators. Well, you can't find the chart, whatever. Ask the nurse, you can't find a nurse, so then you've got to start to do a little triage. So anything that increases patient thickness can create more fog. The valve obstruction, though, that's mainly going to be air, so it's not really going to create a whole lot more, scatter radiation. Acromegaly is usually due to a pituitary tumor. That's an increase in bone, so that's not going to create a whole lot more scatter that's going to distract the image receptor. Okay, so technique adjustments, usually mass, KVP. We can use KVP, but we're going to use KVP where we want to change the differential absorption. So if you have a patient that has acromegaly, then you might want to increase your KVP. Again, addition of bone, you might want to increase your KVP to decrease the exposure to the patient. Most of the time, though, it's going to be mass. So for your bowel obstruction, you're going to adjust your mass. You get a decrease your mass. Ascites, you're going to increase your mass. Why do you not want to increase your KVP if you've got a patient that's full of water? You're going to create more scatter, right? So you already have a patient, their tissue is going to create a lot of water, or a lot of scatter, and then you add water to them, you're going to create more scatter. So you compound the problem. So we're still to the point where we're going to, anytime that we've got a soft tissue increase of any kind, we're going to want to increase our mass, not our KVP. All right, so again, density doesn't automatically increase with patient size, so I want to stop here for a minute. Again, I think I've mentioned this already, and you tend to make a little bit of an illogical last step in progression of critical thinking on scatter radiation. So increased scatter radiation, what is scatter? It's fog. What is fog? It's an unwanted density, right? So what creates more scatter? What patient population creates more scatter? Hypersthenic, right? So now let's add that into the mix. So hypersthenic patients create more scatter. Scatter is a type of fog. It is fog. Fog is unwanted density. Therefore, hypersthenic patients, this is the illogical part where you kind of run off the rails. So hypersthenic patient, more fog, or more scatter, more fog, more density. Yes? Until you get to the density part, right? So you're going to create more scatter, yes. So all of that is true up until you get to radiographic density or image, exposure. All of that is true. The thing is, though, that with the hypersthenic patient, you're going to get more of that scatter is going to be absorbed inside of the patient. So what comes out of the patient is still going to be a higher percentage of fog, right? So you want to increase your mass, you don't want to increase your KVP, you got to increase your mass, otherwise you compound the problem with scatter radiation. Okay, so when you're phototiming, your AECs automatically change your mass, so you don't have to do anything with that. So going back to motion, just parking back on that for a second. How can you reduce motion whenever you're using phototimers? Let's say you got a pediatric patient, you have no idea what kind of technique to use. How can you reduce the likelihood you're going to have motion artifacts?
Change your time.
It's your photo time. The machine selects the time. KVP. KVP is pretty much the only way you're going to be able to do it. And it's a 15% rule all over again. The thing is, when you're phototiming, your MA is set. So if you increase your KVP, the only variable that's going to change then is going to be your time. Your time is going to automatically decrease. Okay. So sometimes people will say, well, select a different photocell. You could do that, but let's say you need the center cell and you select the outer cell. Yeah, you're going to get a shorter time, but you're also gonna underexpose, right? So that just doesn't work. The only thing that's gonna decrease your time whenever you're phototiming is to increase your KVP. So compression might be a thing that you could use to decrease scatter radiation. You're just not gonna see it a whole lot, maybe in mammo. We used to use compression whenever we did IVPs in the department, but we just don't see it anymore. So grids, you know what grids do? Clean up scatter after it's created. Wide angle scatter, that's your Compton. It might not be effective in classical scattering. That's your Thompson. So they do increase patient dose significantly. So they increase dose by generally 3 to 5, maybe even 6 times. So we only want to use grid whenever we have to, right? Grid ratio determines the effectiveness. That's the main thing that determines the effectiveness. Does grid frequency affect effectiveness? The answer is yes, it does. But the main thing that determines the effectiveness is your grid ratio. So remember what to use in calculation of grid ratio. Increased dose with increased grid ratio. The higher the grid ratio, the higher the dose. You got more lead, it's more effective, but it gives the patient a much higher dose. Right. So mass is again going to be your compensation, your technical factor compensation of choice. Also remember, as KVP increases, the grid becomes more effective or more efficient. You may see a question about more efficient with higher KVP. Well, why is that? What's the purpose for a grid? Absorb scatter radiation. What do you create more of that penetrates to the patient as you increase KVP? More scatter. So you got more scatter to absorb, and therefore the grid becomes more efficient at higher KVP. So you got a table in Bushong that you can kind of take a look at and see, you know, what the bucket factor would be with the increased KVP. So remember, we've got 3 types of grids. Each has its own inherent benefits and drawbacks. You know, your focus grid is hard to produce. It's got the leaning grid strips. Also, you'll see those referred to as canting. So if you see canting in the question, immediately you should be thinking of a focus grid, right? So the benefit is that if you look over here on parallel grid, you're always going to have some sort of grid cutoff, because the divergence of the central ray is, you know, you've got the divergent central ray in the periphery of the grid. You're going to have some grid cutoff. You don't have that significant grid cutoff. The only thing that you're going to have are the grid strips themselves being shown. You're not going to have grid cutoff. So parallel are easy to make and they're the cheapest. And the focus is infinite. So when we're talking about focus, again, we're talking about focus grid, and that's the distances that you can use a grid before you get significant grid cutoff in the periphery. Okay? So focus grid, SIDs, acceptable SIDs. Parallel grid, that focus is infinite. But we're always going to have some grid cutoff in the periphery. Also with a focus grid, if you flip it over and you've got the image receptor side facing the tube, then the canting of the grid strips are going exactly opposite from the divergence of the central ray. So what you're going to get in that case is good density right in the middle, and then you get immediate significant grid cutoff. Okay? So the things that are going to cause grid cutoff on a focus grid are an inverted grid, that's upside down, or if you exceed the grid radius, you get too close and the divergence of the central ray is too great for the canting of the grid strips, or you get too far out and the divergence is not as significant as the canting of the grid strips. And finally, you have the crosshatch. These are excellent cleanup. You know, we still have scatter, but if on the focused and parallel grids, if the scatter, it only absorbs scatter across the grid. You know, if the scattered photons are going with the grid strips, then it won't absorb them. With a crosshatch grid, it absorbs scatter radiation in all dimensions. They do have focus crosshatch, which, you know, take two of these and they stack them on top of each other. And the benefit of the crosshatch is that, you know, you get great cleanup. Positioning latitude is, you know, very spotty. You can't angle in any direction with a crosshatch. And with a focus crosshatch, the central ray has to be dead square to the center of the grid. Otherwise, you know, it's kind of like your grid is, you know, your central ray is not perpendicular to the center of the focus grid. Okay, so something else that that you might see on a test is off level, and all off level means is the grid is tilted. Okay, so off level grid's tilted, you're going to get grid cutoff. All right, so we talked about all of that. Diagram for that. All right, so grids and CR, when we talked about this, and we had that aliasing artifact, these two things mean exactly the same thing. It's Moiré artifact. So squiggly lines that you see if you take a picture off of your computer and you look, you know, not a screenshot, but you take a picture from your phone off of your computer, and you see those squiggly lines. That's what the aliasing or the Moiré artifact is. It occurs for the reasons we talked about before, the similarities between the grid frequency and CR scanning. We overcame that by essentially filleting the grids and then, you know, increasing the grid frequency without changing the grid ratio. And that's what it looks like. So most of your departments use 8-to-1, maybe 10-to-1, possibly even 12-to-1, except for in pediatric hospitals where they want a lower dose. They're going to use something like a 5-to-1 safe dose to the patient. So when you look at your grid, what you might see is that it can be used, you might see a number of things. Which side should face the tube, and if it's marked with, you know, SIDs suggested or required SIDs, you're looking at a focus grid. A parallel grid, it doesn't matter which side you put to the X-ray tube, but a focus grid very much does. As a matter of fact, I'd say probably most of your focus grids are going to be built with like a snap-on top, so that you can only use them one way. Right? So grid quality control, what we would do is make an image and you know, put the grid on the image receptor, take an X-ray and look for density differences across the face of the, you know, of the image. So what might cause, you know, a grid to not be any good anymore is generally if they're dropped and it damages the, you know, the spacing of the grid strips, whatever. But that's all we have to do is take take an X-ray and look at the image to see if there's any kind of differences. So we talked about air gap technique and macroradiography. Macroradiography, remember, is not the same as air gap technique. It does inadvertently use air gap technique, but macroradiography is intentional magnification radiography. Okay, so there's a question on the test that, you know, is missed at a really high rate. And what do you do to overcome the magnification in macroradiography? Macroradiography is an intentional increase in OID. So how do you overcome that magnification? What?
You don't do anything.
You don't do
You don't
anything
change anything.
because you want the magnification, right? What you do have to do is use a very small focal spot size, and that is to overcome the loss of sharpness of reported detail. But you want the magnification, so you don't do anything with your SID. Okay, so anytime that you have an increase in OID other than that, you overcome the increase in magnification by increasing SID. But macroradiography, you want the magnification, so you don't do any of that. So your answer would be something like maybe D, None of the above, right? I'm not saying that that's exactly how that's worded, but that would be, you know, a potential answer. So, not the air gap is not the same as macroradiography. It's an increase in OID. And generally, it's a natural increase in OID, like lateral C-spine or whatever. We get that magnification, loss of sharpness, reported detail, so we increase our SID to overcome it. But with the air gap technique, we get this wide angle scatter radiation, misses the image receptor, and works like a very low ratio grid.